Hi, my name is Dr. Eva Minga. I'm one of the cardiology fellows at North Shore University in Chicago, Illinois. Welcome, everybody, and thank you for joining us today. All right. So today absolutely. So for our case presentation today, we have a 68-year-old male who presents with SLL and CLL in 2007. This was diagnosed with an excisional biopsy of the left axillary lymph node. His peripheral blood status shows minimal lymphocytosis with a white blood cell count of 7.8 and 42% lymphocytes. The flow cytometry was positive for monoclonal lymphoid population consistent with CLL, and this was CD19 positive, CD20 positive, and CD5 positive. There was general lymphadenopathy on examination. Okay, I'm sorry. There you go. He was observed until 2009. There was systemic symptom progression. He was placed on a trial using rituximab and alemtuzumab for 5 months, but had clinical progression. Then the decision to receive 6 cycles or RCBP standing for rituximab, cyclophosphamide, vincristine sulfate, and prednisone was made, and that showed partial regression of his disease. Then he was treated with rituximab every 3 months with slow progression of lymphadenopathy. In 2011, he completed 6 cycles of bendamustine and rituximab with CT evidence of complete remission. And then in 2013, adenopathy returned on the CT scan. Ibrutinib was started in May 2014 and was tolerated with a mild skin rash and diarrhea. In 2010, he was hospitalized with pneumonia. He has an EKG with a new right bundle branch block. There were noted bilateral axillary hilar and mediastinal lymphadenopathy. There were also noted upper lobe infiltrates. They were thought to be due to fungal pneumonia, given that this patient had traveled to an endemic area, but he got a biopsy that showed, he got a bronchoscopy studies that showed they were negative. Then later in 2010, he had a small lacunar stroke. So this is his EKG on admission. It just shows normal sinus rhythm and a right bundle branch block. Continuing for his cardiac history, in 2020, he was diagnosed with atrial fibrillation and was started on anticoagulation, apixaban 5 milligrams twice daily. For his stroke that he had in 2010, he was previously on Plavix, and then this is now stopped, given that he's going to be on anticoagulation. In 2020, he also became unresponsive. He had an episode of unresponsiveness that but regained consciousness spontaneously. When he was being evaluated in the emergency department, he was noted to be bradycardic with heart rates in the 20s, 30s, and his EKG demonstrated third-degree AV block. It shows spontaneous conversion to the emergency department. He was evaluated for cardiac sarcoidosis, and he was evaluated by our electrophysiology team, and he received a ICD pacemaker. His procedure was complicated by a pocket hematoma that required evacuation while he was on the apixaban and the Ibrutinib. This was the EKG on presentation during that ED admission that was showed that showed third degree AV block. All right, so this is just a summary of our patient, of everything we talked about. So just as a reminder, in 2007, we have the first diagnosis of CLL. Decision to monitor him clinically was made. In 2009, there was disease progression, so he received treatment with rituximab, alemtuzumab, 6 cycles or RCBP, and then rituximab every 3 months. In 2010, his first diagnosis with pneumonia, and that's where he has mediastinal and hilar lymphadenopathy. This was negative for fungal infection. 2011, he completes 6 cycles of bendamustine and rituximab. There is the resolution of his lymphadenopathy, and then from 2013 to 2014, he has a lymphadenopathy that returns, so the decision to start him on Ibrutinib was made. And then in 2020 is when he has atrial fibrillation, complete heart block. There is a suspicion for cardiac sarcoidosis, and then a BIB ICD was placed. So for this patient, it was felt that he met criteria for sarcoidosis. Then this decision was made by clinically examining him and by doing non-invasive studies. The reason why a biopsy was not pursued is that we had an experience given his pacemaker, and he was at higher risk of bleeding, given that he was on both Ibrutinib and Apixaban. So the decision, the sarcoidosis was diagnosed based on clinical suspicion. So here I'm presenting the cardiac sarcoidosis criteria from the Japanese Ministry of Health and Welfare criteria. So the first diagnosis, you can make it by an endomyocardial biopsy that has about 30% sensitivity. And again, this was deemed to be very high risk for this patient, given his previous history and given that we have him both on Ibrutinib and Apixaban. For the extra cardiac sarcoid, there you can make this histologically or clinically by 2 or more major criteria, or 1 major criteria and 2 minor criteria. The major criteria that this patient met was the advanced AV block. Other major criteria includes basal thinning of the intraventricular septum, positive gadolinium, and then an EF of less than 50%. And then the main minor criteria includes ECG changes with PVC, VT, right bundle branch block, LAD, like left atrial enlargement, or I'm sorry, left axis deviation or right axis deviation, or Q waves, wall motion abnormalities on echo, and then perfusion defect of nuclear imaging, which this patient did have. There was some apical, inferior apical perfusion defect on his nuclear stress test. However, his nuclear stress test was thought to have the inferior wall was read as abnormal, but that was thought to be due to diaphragmatic attenuation. There was then other minor criteria includes delayed gadolinium enhancement on CMR, and then fibrosis or monocyte infiltration on biopsy of the heart. The Heart Rhythm Society also uses steroid responsiveness cardiomyopathy and a positive PET in the workup. So for our cardiac workup for this patient, we did an echocardiogram. His echocardiogram was normal. His YEP, his ejection fraction was 57%, diastolic function was normal. The atrium was read as mildly dilated, but his left atrial volume was 53, and then his left atrial volume index was 27.9, so which falls within the normal range. For his further workup, we did end up doing a cardiac PET scan, and here we're showing basically we're showing the initial cardiac PET scan that was done pre-treatment, and in this cardiac PET scan, there is involvement, there is hypermetabolic activity of the mid and basal anterolateral ventricular myocardium that is most compatible with cardiac inflammation or myocarditis, and then cardiac inflammation, I'm sorry, or sarcoidosis. There is no other hypermetabolic areas that were seen. So based on the clinical suspicion, the cardiac PET scan, and kind of his conduction abnormalities, we decided to pursue treatment with 20 milligrams of prednisone for 1 month, 50 milligrams for another month, and then 10 milligrams for a year. This patient will be followed with biannual echoes, and then serial pro-BNPs and troponin to monitor, and then will undergo rheumatological evaluation. A word on biomarkers in cardiac sarcoidosis. So troponin and pro-BNP are the ones that are most commonly used to follow. High sensitivity troponin has been considered in several studies have been shown to be a reliable parameter in monitoring treatment response. Sensitivity and sensitivity are 87.5% and 75% respectively. It has a positive predictive value and negative predictive value of 87.5 and 75% respectively. As for the pro-BNP, when it is elevated, its sensitivity is 78% and specificity is 67% in patients who you have a clinical suspicion for cardiac sarcoidosis. And this is this patient's PET scan after the treatment. And here we show, so I'm going to go back to the initial one. So here it is his area of hypermetabolic area, thought to be most likely sarcoid, and after steroids we see that there is a significant improvement in this area involvement. We also pursued a cardiac MRI. Of note, the cardiac MRI was pursued after the patient has started treatment, and it was read basically as normal. There was no evidence of late gadolinium enhancement to suggest focal myocardial fibrosis or scar. There were normal T2 times in the myocardium, suggest absence of active inflammation. Right. So I do want to talk about the relationship between sarcoid and lymphoma. Sarcoid and lymphoma can present very similarly, so it's very difficult sometimes to make the diagnosis. There is lymphocytic activations in sarcoidosis and the involvement of reticular endothelial system markers. So both of them can do this. So the diagnosis can be very challenging. It has been reported that up to in lymphoma cases, there is up to 11-fold increase in lymphoma cases in sarcoid patients. So they can definitely coexist. So in this study, there was a retrospective analysis of 112 cases, and they separated the patients in 3 groups. Group A was sarcoidosis preceding lymphoma, and this was the most common type. Group B was concurrent sarcoidosis and lymphoma, and then Group C was lymphoma preceding sarcoidosis. It was noted that the most common lymphoma was the non-Hodgkin lymphoma, then the Hodgkin's lymphoma, and then the interval between onset of sarcoidosis and lymphoma was the longest in Group A, which was the more common presentation. The sarcoidosis preceding lymphoma, as I mentioned, in most cases, the diagnosis of lymphoma was done when splenic or new lymph nodes were noticed, and that's kind of raised clinical suspicion to look for lymphoma in patients who had the diagnosis of sarcoidosis. In patients in lymphoma, sarcoidosis was diagnosed on the basis of new respiratory symptoms, elevated of the angiotensin converting enzymes, ACE, bilateral hilar lymphadenopathy, as well as pulmonary disease. Histological examination is oftentimes necessary and to really make and to distinguish between these 2 entities. A word on sarcoidosis and high-grade AV block. This is a very well-known connection in cardiology, and especially when we have a young patient, we definitely keep the sarcoidosis in the back of our mind. But in this study that was published in Circulation, they saw that in cardiac sarcoidosis, so these patients have cardiac sarcoidosis, they see about 325 patients, and they present with AV block. In patients who had an EF of less than 30% or had documented VT, the 5-year cumulative incidence of sudden cardiac death was about 30%. Patients who their EF was between 35 and 50% and had VT, the 5-year cumulative incidence of sudden cardiac death was 14%. And then in patients who had an EF of 50% and had VT, it was about 90%. So definitely a strong indication for implantation of intracardiac of an ICD device. Whenever you have a patient that you have a clinical suspicion of sarcoidosis and you have a high-grade AV block, like the case of our patient, you should consider placing an ICD. And that's what we did for our patient, and that's the reason why he did get an ICD with his pacemaker. In this study here, so for the high-grade block of this patient, there was two things that we were considering in the differential diagnosis. The first one is definitely sarcoidosis, and then the second is the fact that he was on Ibrutinib. He had developed atrial fibrillation and high-grade AV block, which are known complications of Ibrutinib. So in this study here, they are looking at patients in Ibrutinib who have developed high degree AV block. They are looking at about 18 patients, and these are the characteristics of those patients. They are the male predominantly, even though 53% of those patients are male, 47% are female. The disease that is most commonly associated with Ibrutinib and high-grade AV block is CLL. Second degree AV block presented in 60% of the patients, and high degree, third degree AV block was 33%. And then treatment was more than 12 months in 27% of patients, but the majority of them, the high-grade AV block presented much earlier than 12 months. 100% of patients got a pacemaker, and then the majority of them continued Ibrutinib, while about 38% did not decide to restart Ibrutinib. Ibrutinib and high-grade conduction disorders. So the mechanism of high-grade conduction disorder is not well understood with Ibrutinib. There have been more of in the cellular level studies to show that ventricular human pluripotent stem cells, cardiomyocytes, have demonstrated Ibrutinib potential for direct cardiac toxicity. And then the two electrophysiological findings that have been associated is a dose-dependent shortening of the action potential duration at 80% repolarization and concurrent decrease of the calcium transient duration in atrial, but not in ventricular cardiomyocytes. So it looks like it's Ibrutinib seems to be mostly, at least with this theory, to be affecting more the atrial cardiomyocytes, but not the ventricular cardiomyocytes. Okay. Also, the other theories is that there is decreased cell viability of both atrial and ventricular cardiomyocytes when treated with Ibrutinib. For example, there were none with Acalabrutinib. There was separate work of culture cardiomyocytes. They implicated late sodium current as a tyrosine kinase inhibitor to be mediated arrhythmogenic, like an arrhythmogenic mechanism, which included chronic Ibrutinib exposure. So other potential pathways that have been proposed is that the toxicities may be affecting off-target effects. They have been identified C-terminal SRC kinase or CSK inhibition to be associated with increased incidence of atrial fibrillation. The knockout mice model for CSK has showed increased atrial fibrosis, atrial fibrillation, fibrosis, and inflammation. The downregulation of the PI3K pathway has also been proposed as a potential mechanism for atrial fibrillation, and this has been thought to be related to the TEC protein tyrosine kinases. Mouse studies with inactivated PI3K showed increased incidence of atrial fibrillation, decreased cardiac function, and increased cardiac fibrosis. And then a separate study proposed increased atrial fibrosis through development of reactive oxygen species as a potential mechanism for the abnormal cardiac myocyte sarcoplasmic reticulum. So again, there are many different theories why Ibrutinib can cause high-grade conduction or atrial fibrillation, none of which really have been confirmed, and these are all more on the basic level or on the cellular level that have been studied. Another potential mechanism is that Ibrutinib associated atrial arrhythmogenesis can potentially come from the reduction of ANOTCH1 gene. It has shown this gene has been activated when there is cardiac ischemia as a way to promote mesenchymal stem cells as an antifibrotic mechanism. And Ibrutinib has been shown to decrease this activation, potentially leading to more fibrosis and leading to more arrhythmogenesis. Another possibility that we consider with our patient based on the PET scan was the lymphoma as a cardiac involvement. Lymphoma can definitely involve the cardiac tissue. It's usually it's been reported about 8.7 to 25% in autopsy studies. It accounts for about 9% of the total metastases to the heart, and it was definitely high in the differential diagnosis. However, our suspicion dropped when we got a cardiac MRI that didn't show any involvement. However, the lymphoma involving the cardiac tissue or the heart has been it's usually a very late manifestation of the disseminated lymphoma. Direct extension from the can be from the mediastinal tumor, can be hematogenous spread or retrograde lymphatic spread. The more problematic, or the one that it's mostly more problematic, is the direct lymphoma extension, because this can lead to involvement of the pericardial disease, obliteration of the pericardial space, and then the compression of or the invasion of the heart. This is the route that is most commonly associated with the greatest cardiac destruction. There is predominant epicardial adventition involvement that is thought to result from retrograde lymphatic spread, and the tumor follows the course of the epicardial coronary arteries, occasionally causing compression. The later two patterns are usually asymptomatic. So if this was truly a lymphoma involving the heart, we would expect this patient to do potentially much worse, and we would definitely expect to have MRI evidence for this entity. So in summary, sarcoidosis and lymphoma can be very difficult to distinguish, so clinical suspicion must remain high based on the patient presentation. And both sarcoidosis and Ibrutinib can cause high-grade conduction abnormalities. It's just something to keep in mind when we have a patient that comes with lymphoma and they come with cardiac abnormalities, and the workup and the testing is definitely very, very interesting. Okay, so I do want to thank you, Dr. Jason Robin, for being my mentor for this presentation. I want to thank you, Charlie Robin and Ileana Spitz, who helped me with some of the slides, preparing some of the slides for this presentation. And now we're open to questions.
Great. Thank you so much, Dr. Minga. That's really interesting. I was wondering if you could go back. This is Dan Lenahan, by the way, at WashU. I was wondering if you could go back to the PET image that you showed. So what do you think what are those green spots that show up in that image?
The green spots, I believe those, so this are nuclear, this is what you're referring to. I'm not sure if you can see my pointer.
Yeah.
I think that's, so our nuclear radiologist is the one who pulled up these images for me, and I think him trying to tell me this is what you need to look at. So
is that kind of like X marks the spot? Is that what you mean? So those are not part of the image. Those are just whatever he's trying to point out.
Correct. I think I think he just tried to make it easy for us. That's what I think.
All right, that's good. I like arrows and X marks the spot and that kind of stuff. Those are good. But and then was there a biopsy that told you one way or the other?
No, a biopsy. And
hi Dan, this is Jason Robin. How are you?
Hey Jason, how are you? Thanks for pulling all this together.
Sure. So we did not pursue a biopsy. So on the PET scan itself, most of the inflammation seemed to be in the lateral wall of the left ventricle. So to do an endomyocardial biopsy, I thought that the success rate in general with sarcoidosis is quite low, less than 25%, as you know. And because there didn't seem to be much involvement of the intraventricular septum, I didn't feel comfortable doing a biopsy, especially on someone who we wanted to keep on Ibrutinib, was on anticoagulation. So we certainly could have stopped that for a period of time if I thought that the biopsy would have been fruitful, but I just didn't feel that it would be fruitful. I met this patient for the first time after the pacemaker was put in. It wasn't until maybe a week or two later, one of the electrophysiologists said, it's kind of unusual. This is a very healthy guy who's in his mid to late 60s to just develop heart block out of nowhere. He has a history of lymphoma. Can you see him? So I got involved a little bit later in the course. I do wonder if we think back to 2010, 3 years after his initial diagnosis of lymphoma, when he was hospitalized for quote unquote fungal pneumonia after he was out in Nevada, if that was his earliest manifestation of sarcoidosis, where he had hilar and mediastinal adenopathy at that time and upper lobe infiltrates. I wish that we would have had a biopsy done at that point to differentiate, was this infection, which again, nothing ever came back positive for fungal cultures, was this his lymphoma, or was this the initial manifestation of sarcoid at that time? And the upper lobe infiltrates plus the mediastinal and hilar adenopathy, certainly the hilar adenopathy, makes me wonder if that was his initial manifestation. What makes this case very challenging, probably more for the oncologist than the cardiologist, is knowing the relationship between lymphoma and sarcoid, and you have someone who's thought to be progressing with their lymphoma, and could it be that all along this wasn't progression of lymphoma? What we were seeing is sarcoidosis over the years.
Yeah, I mean that's a potential consideration, and Dr. Minga is showing the one study where there was a combination of lymphoma and sarcoma. Was really interesting. I really wasn't aware of that. But going back to your PET scan, there are two spots that look a little warm to me. So I was just wondering if those could have been biopsied. So for example, it looks like there might be a tiny little node in his cervical chain, and then definitely in his left shoulder that looks a little warm. Did they ever think those were abnormal? Did we lose video or audio rather?
I can hear you, Dan, but I can't hear a response.
Yeah, I don't know what happened. It looks like they froze.
Is that just a way of not answering the question, or?
That could be an avoidance.
Hey, Dan,
or were they trying to shut me out?
it's Joe.
That's also possible.
Can you hear me?
Thank you for being
Yes.
here, Dan.
Yes,
Dan.
Joe.
Yeah, you can hear me. So we've had a couple of patients like that we were asked to see that didn't have bundle branch block or heart block, and that we've always opted or recommended biopsy, not myocardial biopsy per se, but to get tissue because as Jason said, oftentimes, patients continue to get treated for lymphoma with potentially not only cardiotoxic but toxic medications, and we saw that Ibrutinib multiple cytotoxic chemotherapy regimens that even though the flow cytometry is normal, we really do push for biopsy.
Yeah, I mean, I think the challenging.
Hello?
Hello.
Okay, sorry, we're back. We lost audio for a second. So I'm sorry, Dan, which area would you think about biopsying?
Well, the left shoulder, and then it looks to me like they're right just below the left clavicle is a little bit of a warm spot. So I don't know if there was a palpable node. No, on the other side, on the left side, right there.
So I think that's his a pacemaker, if I'm not mistaken, because I think this, he got his pacemaker here. And I don't look at this very often, but like, I think this is his pacemaker, and I think this might be part of his leads.
Yeah, Dan, I think that's a great point. You know, it's interesting. The radiologist who read the PET scan didn't make any comment at all about any hotspots. I certainly see what you're saying, and I'd like to get back to the group and let them know what the radiologist thought was on that spot. Again, they mentioned no adenopathy anywhere, so I'm not sure if that's artifact or what, but there was no comment on adenopathy or anything else to go after. So I imagine it's some sort of artifact.
Well, and then, and so then this brings me to like one of my favorite topics of, when we start looking at PET scans. So I know just enough to be really dangerous, and but I end up looking at an awful lot of PET scans because, people are getting it for cancer purposes. And, it's interesting that you say the radiologist didn't mention anything about it. And if you look at, just look at the next 10 PET scans that you have in patients, presumably for their cancer, and tell me what you see in the heart in general. So for what you'll see is a wide variation, and you'll look at some person that's completely healthy from a cancer perspective, and their heart will light up completely, and then you'll see other people that have, extensive lymphoma or something else, and they got lots of hot spots, and you'll see these big patchy spots of the heart. And for the most part, it's very rare actually that you'll see virtually no uptake in the heart. And then if you ask the radiologist about it, regardless of whether it's patchy or really intense, they'll say, oh, we don't even look at the heart. We don't know anything about it, so we don't really even read it. And so they usually just completely ignore it. So then in this case, you see some PET uptake that's in the lateral wall. I mean, how is that not just within the range of your average PET scan?
Yeah, that's a great point, Dan. So what we didn't mention is that this was actually a sarcoid protocol PET scan where we put the patients on a 3-day ketogenic diet where they're not able to have any carbohydrates at all for 3 days. And the thought process is with the cardiac PET, as you know, that normally most of our hearts like to use fatty acids and whatnot for their energy. It's probably 60-40 fatty acids to carbohydrates, maybe 90-10 fatty acids to carbohydrates in some of us. What we do though is we do a 3-day ketogenic diet where we totally allow no carbohydrates at all. And then when we give the 18 FTG, the thought is if the heart is completely normal, there should be absolutely no uptake whatsoever. So this was not just a standard 12-hour, no carbohydrate PET. This was a 72 hours. So when we see uptake in the heart after 72 hours, then our differential is either they're ischemic, which shifts the metabolism more to carbohydrates with ischemic tissue or inflamed tissue. And what we're doing right now is we're doing a clinical trial right now looking at checkpoint inhibitors and using PET scans to try to make the diagnosis more in the melanoma patients who are going to be getting PET scans on a serial basis to look at uptake. But this was a 3-day ketogenic diet. So in most of our patients, we're very, very good at suppressing all uptake of the 18 FTG in the heart with the 3-day ketogenic diet.
That's interesting, but yeah, so at least at this point, you're feeling reasonably confident that this is uptake in the heart that is potentially abnormal. So, but then I would also say that that left shoulder looks a little bit abnormal. So that may be a source that you could biopsy.
I agree, and we're gonna have to talk to the radiologist. And let's see, we should look at the post PET scan just to see if that left shoulder thing is still there. And it's
providing a different image.
It's a slightly different image. I can see what you're talking about. Still, something looks like it's slightly warm in that left shoulder area. So we'll have to talk to the radiologist about that. But certainly in the heart, the degree of inflammation seems to be less after a course of low-dose steroids. And the reason I chose low dose, normally with my sarcoid patients, what I'll usually do is I'll put them on maybe 60 milligrams of prednisone daily for the first couple of weeks or so, then slowly get them down. We know that in general with sarcoid that low dose is really just as good as high dose. So usually that cutoff point is about 30 milligrams of prednisone per day. So I try to get them down to less than 30 milligrams as soon as possible, because I already had the ICD in him. He has obviously he's got a pacer ICD. I wasn't too concerned about conduction issues or ventricular arrhythmias, or less concerned with it, and his EF was normal, so I didn't feel obligated to blast him with steroids. And I thought that if his PET scan looked worse at follow-up after the lower dose of steroids, then maybe I would get a little bit more aggressive. The fact that the PET scan looks better from a cardiac perspective and the troponin normalized after steroids makes me think that we're probably on the right track with him. The one thing that I still wonder, though, again, without a tissue biopsy, again, I'm saying sarcoid based on the known relationship between lymphoma and sarcoid, as well as other cancers in sarcoid as well. I've had a couple of patients with testicular cancer, and there's a well-known relationship between testicular cancer and sarcoidosis. Because of my high clinical suspicion this was sarcoid, that's why I'm doing the treatment. But I still wonder if this is Imbruvica related. And I do have a couple other patients who I have on Imbruvica who have developed what seems like a myopericarditis, and I have no other good explanation for it. So I do wonder, with all the AFib that we're seeing with Imbruvica, could this be an inflammatory type reaction from the Imbruvica? And it would be interesting to be doing PET scans with a 3-day. Again, the key is to do a 3-day ketogenic diet. You can't really interpret the heart on a PET scan. It's a 12-hour ketogenic diet. It has to be 3 days to completely shift the metabolism to all free fatty acids. But could that be a mechanism of AFib with Imbruvica? Certainly there's been this one paper, which is a small cohort study of only 15 or 20 patients, that seemed to show a relationship between Imbruvica and heart block, which is something that we certainly don't see very often.
And so this follow-up PET scan, was it done by a similar mechanism?
Same thing, so 3-day ketogenic diet after he had been on steroids for several months.
Great. Yeah, so no, I think this is a really fascinating case. It's hard to sort through those things, but I think that the treatment of sarcoid is pretty nondescript in terms of, it depends on how sick somebody is and how active you think their disease is, whether you should treat them or not. So it's a challenge, and to have a parameter to follow, I think is very important.
Yeah.
I have 2 questions. It's Joe. First is, did he go back on Ibrutinib? And the second question is, how much, when you interrogate the device, how much pacing is he doing?
I'm sorry. So as far as the second question, how much pacing? He's 100% paced. So certainly he needed the pacemaker, and so he's had the pacemaker in. This was put in December. So yeah. So for the past 6 months or so, he's been 100% V paced. Fortunately, he hasn't. And again, when we put in the ICD, I wanted it to be a bi-V ICD, even though his EF was normal, just because my experience is a lot of these patients who have heart block where sarcoidosis is not diagnosed, we put in a typical dual chamber pacemaker, they become RV paced, and I feel that there's a high percentage of these patients who develop cardiomyopathy from chronic RV pacing. So my feeling is once we make a diagnosis of sarcoid and they need a pacemaker, I usually just make it a bi-V ICD, so that way we don't need to upgrade down the road. So the heart block is persistent. It hasn't gotten any better. That part has not gotten any better with the steroids. So it makes me wonder if there could be some scar tissue there, although we did not see any scar tissue on the MRI. Although my experiences with the MRI, we often miss things with sarcoidosis for whatever reason. It's not the perfect imaging modality. I didn't hear the first part of your question.
Yeah. Did they restart the Ibrutinib?
Did they restart the Ibrutinib? Was basically.
Yeah. So the Imbruvica was never stopped. The only time I stopped it was when we upgraded him from the pacemaker to the BIV. And I should mention that when, again, I wasn't consulted when he initially came in with the heart block. He was on Imbruvica at that time. He did develop a pretty significant pacemaker hematoma while on Imbruvica, because I don't think that the electrophysiologist recognized the bleeding potential that comes with Imbruvica. I did stop the Imbruvica for about 3 to 5 days before we upgraded him from the dual chamber pacemaker to the BIV ICD. But that was it. The Imbruvica was not stopped. So the fact that he's continues to be paced all the time tells me that there is scar tissue there around the AV node. And again, is that related to sarcoid or is it related to Imbruvica? Hard to say. With sarcoid, often the heart block gets better with steroids, but not all the time. And we are still seeing a little bit of inflammation on the PET scan. So there still could be a little bit of active inflammation there. If this is related to the Imbruvica, then again, well, it never got better. So it could be that the Imbruvica could be causing the heart block as well. And if that's the case, then he may not need to be on the steroids, although he's tolerating it at a very low dose. And I'm pretty comfortable having him on just 10 milligrams a day of prednisone right now.
Yeah,
There's a couple questions.
Yeah, I think the other issue, which is basically what Joe brought up, is that is Imbruvica the best medicine for his lymphoma at this point? And if you have a serious rhythm problem on Imbruvica, I think that I would at least give serious consideration in terms of stopping it. But
yeah,
you might, if he's got a functioning device, I mean, he's protected from VT, but did you say he has a BIV pacer or BIV ICD?
BIV ICD, so he's protected on both ends, bradycardia and B.
Yeah. So I mean, I think that whether that's the best therapy for his lymphoma at this point is a question.
It's a great question. And, if we look back again, his initial diagnosis was in 2007. So from 2007 to 2014, he kept having quote unquote progression with pretty aggressive therapies. Now, in retrospect, was this progression truly lymphoma progression or was this sarcoid? We don't know. But in 2004, so he's been on Imbruvica now for about 7 years, and his disease has been very, very stable for the last 7 years on Imbruvica. So, I would hate to stop the Imbruvica based on how stable his lymphoma seems to be. And again, from a heart block perspective, we're covered, and from a ventricular arrhythmia perspective, we're covered too. A lot of times with these sarcoid patients, what I'll do is I will have them do more frequent interrogations of the device, just to see if we're seeing any uptick of ventricular arrhythmias, or even ones that are not necessarily treated. And for my sarcoid patients, if I'm seeing that they're having a lot of runs of non-sustained VT, I'd like to prevent them from getting shocked or have their device being used. So I'll sometimes start them on medicines like amiodarone, or even consider VT ablation, although our success with VT ablation in sarcoid has not been spectacular. And in this case here, because most of our disease seems to have been located on the lateral wall of the left ventricle, I would think that we would have even lower success if that's where the scar is located.
I don't know if you can see the questions part of the webinar, but the two questions that are in there, and I would encourage whoever put them in to ask the question, but one was what you just answered: would you consider switching it to another agent? And then the other question was, is there any data of cardiac, let me see here, I have a hard time reading this one. Cardiac PET CT in patients on Ibrutinib demonstrating absence of uptake in controls. I guess the question is have there been any comparative studies of PET scanning in people that have, lymphoma cardiac uptake?
Yeah, that's a great question. There is absolutely no data out there looking at the utility of doing the 3-day ketogenic diet and doing PET CT on patients with Imbruvica. Again, we're doing, and Dan, this trial that we're doing here is very much sparked by you, because when I presented about a year or so ago on a case of checkpoint inhibitor-induced myocarditis, and this patient was getting serial PET scans, you were the one who pointed out on a PET scan, if you look at the PET scan, this was a melanoma patient from time A to B to C to D, as his melanoma was getting better, we were seeing increased uptake in the heart. Now, again, this was in a patient where we weren't doing the 3-day ketogenic diet, but we ultimately did diagnose this patient with the myocarditis. So it was you during one of these discussions that prompted us to do a clinical trial, it's called the PET mice trial, where we're looking at PET to assess myocarditis with immune checkpoint inhibitors. And
Cool. It's really good to know that I'm at least internally consistent. So
you're internally consistent for sure. And the thing is, it's a little bit easier to do it with the melanoma patients, because these patients typically get serial PET scans to look at progression. It's not easy to get these PET scans covered by insurance. So for the melanoma patients, it's easy because that's part of the protocol. These patients get PET scans. So a lot of these other solid tumors and whatnot, they don't always do serial PETs. And for lymphoma or CLL, SLL, it's not something that I'm aware of where they're getting serial PET scans. But if we could get some funding and we could do that, I think that would be a fantastic multi-center collaboration study, looking at patients on Imbruvica and looking to see at a PET scan at baseline and with a 3-day ketogenic diet, are we seeing an increase in inflammation of the heart, and could that be part of the pathophysiology of the AFib that we're seeing in 10% of these patients?
cool. Yeah, no, it's really fascinating, and these are great images. I think this is a really challenging situation. So I'm glad you went through all this process.
Well, I'm going to tell you that Eva, my fellow, gave Cath conference this morning from 7 to 8. She's doing this from 8 to 9. We're both on call at the hospital right now. She's covering a service of about 20 patients, and she's got a baby at home that is about, what, 6 months old? Oh, 3 months old. So she's an all-star.
Well, it sounds to me like you need to give her more to do.
It looks like Gagan Sani has a question. Gagan? Nope.
All right. Well, thank you so much. And Iva, keep up the good work. Just, make sure you get some sleep and, don't wear yourself out.
Don't want anyone out there to steal her. When she's done with her fellowship, we want to keep her here. So no one try to steal her.
All right. Well, you know where we are. We're in St. Louis at WashU. So, be careful.
All right. Thank you very, very much. I appreciate it.
Thanks a lot.
Yeah, thank you all.
Thank you all.
Bye-bye.
Appreciate it. Very
Thank
good.
you. Congratulations.
Thank you.
Mutation.